I'm Dr. Arno David Hausman, and you've discovered Vital Signs, a public service program sponsored by Phelps Memorial Hospital, and a program that looks at medical issues in the news in an in-depth way. Today, we'll be talking about non-surgical treatment of the arthritic knee. Dr. Seebacker is a graduate of Georgetown Medical College and trained at the Hospital for Special Surgery, Cornell, and also did a fellowship in the Hospital for Sick Children in Toronto. Dr. Seebacker has now been working on a new non-surgical treatment for the chronic arthritic knee, and certainly worth speaking about. Dr. Seebacker, welcome.
Good morning, Arno. Nice to be here.
to our program today. Knee problems are fairly important. How many people are suffering with chronic knees, debilitating knee problems that require therapy?
Probably over 30 million Americans. The knee is the most prone joint in the lower extremity, below the waist, to develop arthritis. It's sort of out in the breeze between two very long bones, and that's what makes it such a prevalent and common problem. More and more as people live longer and are more active, the knees wear out, and they want to have relief so that they can keep up their active lives.
Now, in our environment today, we have people who are both physically active, joggers, runners, lifters, people who are doing spinning and all kinds of activities. At the same time, we have a large number of people who are overweight and putting a lot of stress on that knee. And as a result, they're having problems at relatively young ages. You're seeing people who have significant arthritic changes in their knees at what age?
It's creeping down, as you've alluded, although fighting those tidewaters are the sports medicine orthopedists who try to keep people's knees in tip-top form by reconstructing their ligaments. In the old days, torn cartilage, or meniscus is the correct term, were removed. Today, sports medicine doctors try to repair them, so they're doing their best to prevent arthritis from developing, but in the end, we still see many people with it by their fifth decade or in the 40s.
Now, the classic presentation for a person who has a knee replacement, what are the classic findings with the orthopedist? What is he looking for, and at what point does he say, no, looks like you might need a new knee?
Well, a knee replacement becomes an option when a patient has had other surgical procedures performed and they've no longer helped, or there are no other surgical procedures with reasonable expectation of working for them to undergo. And those would be people who have a story or a history, as the doctor calls it, of a painful knee. It keeps them awake at night. It's hard for them to walk, to climb stairs, to get in and out of a car, to dress themselves. They have to have a bad story. Additionally, as the doctor, I would want to see a knee with some type of problems, which is to say a limp or swelling or incomplete motion, weakness of the muscles that have developed because of inactivity and lack of full motion. And finally, and of equal importance for each of these three criteria, would be to see an x-ray that shows that the knee is truly worn, that the spaces between the bones on the x-ray have collapsed down from wear of the pearly white cartilage you see on the end of a chicken bone, and has disappeared, and so what you see is what people call bone on bone. Without those three things, a bad story, a bad exam, and a bad x-ray, it would take something very special to indicate that a person was a candidate for a knee replacement.
There's three classic criteria, and one, you have to have a good story. You probably had multiple procedures, and you've kind of reached the end of that line. You have deterioration of the tissues not only of the knee but around the knee, and finally x-ray findings that are supportive of a person who needs a new structure there. Now, if you replace a knee, how long does that last, a brand new replacement?
Well, of course, that depends on how old the person is who's having the knee replacement inserted, how much they weigh, and what they intend to do with it. We think that the knee replacements that we're putting in now have the potential to last 30 years, but that's in the right patient. So the doctor has to be judicious, and the patient has to expend all other options before they go to the knee replacement if they're young.
Before you've replaced over 2,000 knees. So you're pretty experienced in who should have a knee replacement and how they're going to do over the course of time. And yet there's a large segment of the population that are not candidates for knee surgery for a multitude of different reasons.
Well, I think it's important for the surgeon to be experienced and to have the patient's best interests at heart. and to realize that not everybody who is passed on to me, say by my partners who are sports medicine doctors, coming to me saying, my knee hurts, I want to be restored, I have to exercise discretion and say to some of them, let's try something else first, because I don't think you're quite ready for the knee replacement.
For what reasons would you not replace their knee?
Well, either because I think they're too young or the arthritis is not yet bad enough. If I truly see that they have bone on bone and a good amount of it, then I'm comfortable offering them a knee replacement as long as they don't have unreasonable expectations. So if they're working as a Con Edison pole climber, they would have to understand that with a knee replacement, you can't climb telephone poles anymore. So they have to have reasonable expectations and they have to meet the criteria. If they don't, then I have to try to persuade them to try something else, and that's where my suppression program has developed in part.
You talked about people who fall into a gray zone. We were talking before the camera started to roll. People who fall into that, what you call the gray zone. Define the gray zone.
Gray zone is this area between when the sports medicine experts have expended their traditional efforts of what is known and works the best and are starting to think about offering less perfected techniques or techniques that have lower success rates, hoping to avoid replacing a knee. Everybody says, well, it's best to work with your own parts, and I think that's a good principle. We don't want to fill your knee up with artificial parts that have a definite half-life of how long they're going to last, unless we've done everything first. But the problem is that a lot of the operations that are being employed don't have the high success rates of a knee replacement, and not all the patients who have them are equally satisfied, and certainly not as satisfied, say, as an operation like trimming a meniscus or repairing a meniscus with an arthroscope or replacing a knee. These are operations that have very high rates of success.
People essentially they have bad knees, but they're not quite bad enough to require surgical intervention.
Well, in my
or
opinion,
replacement.
I will say that knee replacement has become an easier operation for several reasons. Better prosthetic designs that flex the knee easily and the patients don't have to fight as hard in rehab, and ways to block pain after surgery with very thin tubes that are inserted in the groin to the nerve that goes down to the knee so that pain is really blocked after surgery. And although knee replacement has lost some of the reputation of being a very difficult operation, I think in principle it's still best to try to work with the patient's natural knee as long as you're able, if you are able to provide the patient the same high level of life and performance and satisfaction.
No, we're talking about people who they have pretty bad knees, but their knees aren't quite bad enough for replacement. You have people who are just not candidates for surgery, maybe perhaps because they're too ill or too old or have other medical problems that make them poor surgical candidates. And then you have people who just can't do it because of the circumstances of their life. These are the people that would fit the best in that non-surgical management, correct?
But today I find myself with about 500 people that I'm treating non-operatively who have knees that are arthritic. And as you said, and as we discussed, there are three basic groups. There are those who think that they want a knee replacement, but I'm fairly confident that I can still help without taking that big step. And certainly
that could be any age group.
Yes, it can. But certainly for those people, I would say it's worth a try. Let's try it for 3 or 6 months and see what happens. Secondly, there's a larger group of people who really are good candidates to have a knee replacement. They would only have to say yes, but there are various circumstances in their life, either social or economical, where they just can't take the time from work, from nursing a sick relative, from getting ready for a wedding, or some pressing occupational project where they just don't have the time and they say, Doc, you got to buy me 6 months or a year. What can you do to help me?
Use this new treatment as a delaying tactic.
And of course, once we start that and then it works, those people are going to say, I don't want to have the surgery. And so oftentimes they continue in that 3 years, 5 years. It is my responsibility for those kinds of people to make sure that they don't deteriorate significantly as far as deconditioning, obesity, inactivity, their heart starts to become weak or bad. I have to watch them carefully and not let them lose the opportunity to have the knee replacement that they might someday need, because they would then wind up, if I did that, in the third category, which are people who clearly would benefit from having a knee replacement, and I would like to offer them one, except that they're too sick, and the risk of doing it would be too great for them to have a knee replacement. People on chronic dialysis, people of advanced age, people who've had strokes, people who have severe Parkinson's disease, people with very poor circulation, people who have other complex diseases.
You can offer them a significant change in their quality of life.
Many of them we can help, and it's certainly worth a try, yes.
So you're saying, basically, the people that you're saying that apply for this non-surgical management program, these are people who may have seen lots of other doctors, including yourself. They've had maybe multiple procedures. They are varying age. They could be quite young, in their 40s or 50s, or even in their 80s or 90s, but they're debilitated by their knees. Some are not quite ready for surgery. Some are unable to have surgical intervention because of their life circumstances. Some just are never going to be candidates for intervention. And yet you're able to take, and it must be a fairly large population, you're able to take these people and through various management technique, you're able to make them far more comfortable. So exactly what are you doing? This is a person, they've been through the doctor's offices. They're fairly sophisticated. They come to see you. What's the first thing you tell them?
Well, they come to me and they're in pain, and they're most interested in having the pain stopped. And interestingly, the main cause of pain in an arthritic knee is inflammation. Now, that's a simple word that describes a lot of different chemical and biochemical features that are going on inside an inflamed knee that make it swollen and tense and stiff, and sometimes hot, painful even at rest. The first thing we want to do is stop that inflammation and make them comfortable, to eliminate the swelling, and then gradually, under the control or protection of what we've done to stop the inflammation, we then begin the second phase, which is to restore motion in the knee and gradually strength in the muscles around the knee and the joints around the knee, as far as flexibility in the hip and ankle and back, so that the body, the lower portion of the body, becomes a spring able to coil up and protect the damaged knee, and therefore the knee which is damaged takes less physical abuse, less hits, and begins to become naturally less irritated. Of course, the natural cycle with the medications and shots that we administer to control inflammation is that after they're completed, the inflammation starts to creep back in, even if all the positive and good things have happened. So we're able to reoffer those shots and pills again on a cycle.
So there's basically three steps. Number one, deal with the pain. By dealing with the pain, you're talking about eliminating the inflammation, or at least diminishing it.
Yes.
The second thing is protecting the knee. You can't do much with the knee itself if you're going to leave it there, but you can do quite a bit by strengthening the tissues around, above, and supporting the knee. And last but not least, you have to recognize that this is a treatment that you have to repeat periodically every 3 months to make sure that the medications remain in place or that are replaced as the body uses them up. And those 3 steps, you've been fairly successful.
We began this technique a little over 5 years ago in its current form, and I would say we've treated at least over 500, many of whom are still in the program. People leave the program either because they're dissatisfied with it, which is a small fraction, or because it stops working after a while and we replace their knee, or because they die.
So we're talking about, again, a procedure that people are seeing because of pain. They want to avoid an operation for one reason or another. You're able to alleviate, if you're either not able to alleviate the pain, in which case they obviously need the operation. You're able to alleviate the pain for long enough until they can have the operation, or you alleviate the pain adequately so that they don't need an operation during their natural lifespan. I mean, that's great. Now, the steps that you have to take, what the first thing, alleviating the inflammation. You get rid of the inflammation. How do you do that?
We inject the knee with a medication which is a cousin of cortisone. And it's important to realize it's not cortisone. It stays in the knee because it's not soluble in water. It's been chemically modified to stay in the knee, and it works there for about 3 weeks. And at the height of its action, it takes away 95% of the inflammation, and the swelling and the pain and the redness and the warmth begin to disappear, and the knee feels pretty good.
How painful is the injection itself?
Virtually not. But it's very important that the injections be given in a special way that ensures that they always get into the knee joint.
So it has to be in a very precise location. And how do you ensure that that location is
Well,
achieved?
for the majority of patients in an experienced surgeon's hands, you can put the needle where it has to go, just relying on your hands and your eyes and your sense of the anatomy. But there's a certain group of people, either who have very big bone spurs, or are themselves very heavy, or have varicose veins all around their knee, or deep skin creases from obesity, in whom finding the center of the knee cavity to inject the medication is more difficult. And for those, we have ultrasonic image guidance, which I perform in a way which is rapid. We freeze the skin first with a small amount of a chilling spray. The patient rarely feels the needle going into the skin, and if the needle is directed quickly and instantly into the deep center of the joint, the whole process of getting a knee injection takes about 3 or 4 seconds at most, and almost always ensures, with the ultrasound as a backup, that the shot will be in the right place to do its job.
How long before they actually feel the medication working?
Within a day, 2 or 3 days at most.
And you
should
say it
be doing
remains
its job.
effective for at least 3 weeks.
2 to 3 weeks.
Do you need
about.
another injection in 3 weeks?
Well, the ideal thing is at the height of the suppression of their inflammation,
So it's about 2 weeks into the
a
shot?
week. With this medication that I said is a cousin of cortisone, we then would intervene and put a second medication in, which is a syrup-like material, which mimics the lubricating syrup that's in the knee itself, in the joint. And even though it's not the exact same thing, it's closely related. And the presence of those molecules in the knee, which has already been suppressed or quieted with the cortisone, and I use that as a misnomer, then causes the knee to become even quieter and prolongs the good effects of the cortisone
Steroid.
from 2 to 3 weeks to somewhere between 8 and 10 weeks. If we just gave the steroid shot, the cortisone, if we just gave that, it would wear off in 2 to 3 weeks. But if we intervene at about 7 to 10 days and put in the second shot, the mucus, which is hyaluronic acid, which goes under different brand names like Supars, Orthovisc, Synvisc, Hyalgan, any of these different brands that people use. If we put that in next, then what we find is that the knee stays quiet for 6 to 8 or even 10 weeks. It doesn't matter if you put in 2 or 3 of those HA or syrup shots. 1 is enough if it's put in the right setting, and 2 does no more than 1. I should say that in the beginning, the thought was that those hyaluronic acid molecules were going to rebuild the cartilage of the knee. It's long been known that they don't do that. They're only there for a day or two, and at most, if there's no inflammation, they turn off certain receptors, block certain receptors in the chemical systems of the knee that prevent inflammation from quickly redeveloping and keep the knee quiet for quite some time. Obviously, in a damaged arthritic knee where there's ongoing trauma, the simple act of getting up from a chair, going downstairs, releases chemicals from bone on bone that don't normally occur in knees and start the inflammatory process again. If you've made your muscles strong, you can substitute other muscles and joints for getting up or climbing stairs and reduce the amount of mechanical trauma in the joint. But sooner or later, it creeps back, and the studies have shown 8 to 10 weeks is about the longest you can affect this process. And therefore,
So then 8 to 10 weeks, you start over again.
That's correct.
And then you start with a steroid injection, followed by hyaluronidase injection.
Yes, a week later, right.
Okay. And you can keep on doing that every 8 to 10 weeks for how long?
So it's every 12 weeks we give the shot.
That's even longer.
And we repeat it. That's therefore a patient is going to be visiting the doctor 4 times a year for 4 series of shots. Actually, it's 2 shots, so it would be 8 visits a year, a week apart every 3 months. And I have people who came to me for an arthritic knee, were satisfied with these treatments, and have been going on with them for 7 and 8 years now.
And this is now covered by insurance.
It's covered by most insurances, yes. Certainly Medicare and most of the private insurances, workers' comp, and no fault.
Now, you'd mentioned that the regrowth of the cartilage over the articular surfaces where the 2 bones come together, that there's no technique now to regrow that tissue. And I assume you have people who've been treated now for about 5 years, maximum. And they're still functioning perfectly happy, able to do pretty much what they want to do within the obvious limitations.
Well, it's closer to 10 in the sense that prior to 5 years ago, I was giving these shots the way that the government and the manufacturer had recommended, which was 3 of these syrup shots every 6 months. The problem with that, which we did for a number of years, myself and a group of doctors of physical medicine here at Phelps Hospital, was that after 8 to 10 weeks, when the shots wore off, there was no answer. For the next 4 months, there was nothing to offer those patients other than perhaps a repeat steroid shot or anti-inflammatory pills. I learned back in the prior 5 years that when we were having these problems after 8 to 10 weeks, that the Japanese were dividing the shots up and spreading them out, and in effect giving the syrup shot, one of them, every 3 months. And I had already determined and learned that it was better to quiet the knee before putting the syrup shot in, which is the hyaluronic acid, with a steroid shot first. Steroid shots have been studied very extensively in the orthopedic literature in the past, and the generally accepted principle is that they're safe to give them. These water-insoluble steroids, which can't go anywhere else in the body, can be safely given into a knee joint every 3 months. And I then added, following that a week later, with the sodium hyaluronate or syrup. And that's how we hit on that combination. So some of the patients I mentioned who've been happy for 7 years were people who were receiving it the old way with some success, not as much, and then converted to this newer way of every 3 months and stayed satisfied or became more satisfied, and have continued up to the present in that treatment.
You planning on writing this up? We going to see a publication?
Yes. What's missing as far as a publication is getting a research assistant who will go into my records, which are all computerized and very detailed, and extract every patient that I've treated in the last 5 years this way, analyze how long they stayed in the program and what became of them if or when they left it, why and for what reason. And once I have that data, which will probably happen in the next few months, I will put it together into a paper for presentation at a major orthopedic meeting and submit it to an orthopedic journal.
Now, other than a forum like this, have you been able to get this information out so that this is an available therapy for people locally?
I've given talks at various community centers and other venues through the hospital, articles in magazines and newspapers, and on websites.
It's really very exciting. It's very exciting sort of, non-surgical therapy to keep people out of the OR, at least for, the amount of time that they're able to.
Well, clearly it's exciting for the people in whom it works. And there's really very little harm in trying it, if any harm in trying it. I always tell new patients coming in prospectively that the minimum effort is 6 months, and I'll tell you why that's so. For the first 3 months when they're in physical therapy, that's pretty rigorous because it's not just therapy to maintain their strength and flexibility, it's to build it. So sometimes in that first 3-month period, patients need a little extra help. This is not therapy that consists of hot packs and massage. It's real exercise to build muscle bulk in critical muscles, as I stated. And some of those patients do need an anti-inflammatory agent like Motrin or aspirin or Aleve, or sometimes a painkiller like Tylenol. By the time 3 months go by and now they present with a stronger knee and are just doing maintenance exercises, much easier exercises to maintain the strength that they've gotten, now they're ready to really see what happens when they get those 2 shots a week apart, back to back, and have 3 months with their newly strengthened muscles and their suppressed quiet knee. So by the end of 6 months,
So these three of the three legs of this treatment, the three arms of the treatment actually, the one that's equally important is the patient's own activity, strengthening those muscles, strengthening general physical strength. Obviously, if they got a bad right leg, they got to make sure their left leg is stronger. And once they've done that, the physical therapy, which obviously plays a major role in the care, the actual injections, and then the maintenance therapy of injections will be most effective.
right, and we don't mollycoddle these patients. Once we get them on plane, like a boat coming out of the water, I encourage them to be as active as they can be. If they want to walk for activity, walk for activity. If they want to get an elliptical trainer or a cycle or do special weightlifting, all that's fine. Playing tennis, skiing, whatever they want to do, we want them to do it. Ideally, my goal would be that if they come to me with a knee that's held them back for a year or two and they've become deconditioned from it, I'd like to see them get back up to the level of conditioning they were in before that knee started to slow them down.
Well, I found this fascinating. You know, it's pretty obvious that total knee replacement has made giant leaps and bounds over the years. The products available to replace knees, they are using materials that are space age. It's really 21st century stuff. But that not everybody can tolerate the surgery, and not everybody can undergo the surgery when they wish to, and not everybody who might benefit from surgery has actually reached that point where they actually need the surgery, that there's an alternative for them. That's a wonderful option. It's something that I think you've made a major contribution to medicine in general, certainly to our community specifically. And I hope that people are able to take advantage of that. I hope that you, the watcher, the listener for today's show, will pass this word on to your friends, that there is an alternative to surgical intervention, if only for the short term for those people who need it, and maybe for longer for those people who can await other treatments that are slowly in evolution. It's a fascinating talk, and it's a wonderful thing that we have this alternative here at Phelps, and I got a feeling that your colleagues are going to be picking up this alternative also fairly soon.
Thanks for the opportunity to be here.
Yeah, I'm glad you're able to come.
Thank you.
Anyway, thank you for watching Vital Signs. I hope that you continue to watch this program, and that you take home a couple of lessons and some information you can pass on to your friends. We'll see you next time. All the best of luck.